Dames en heren, welkom bij deze inaugurede, de inaugurede van professor Hans-Peter Brunner La Rocca, benoemd tot bijzonder hoogleraar cardiologie with a focus on clinical heart failure in the Faculty of Health Medicine and Life Sciences. De titel van professor Brunner La Rocca's oratie is Towards Personalized Medicine. Professor Brunner.
Meneer de rector magnificus, decaan, vice-decaan van de faculteit Health, Medicine and Life Sciences, gewaardeerde collega's, lieve vrienden en familie, geachte toehoorders. In principe zou ik mijn oratie graag in het Nederlands willen houden. Niet om te laten zien dat dit toch wel redelijk zou lukken. Ook niet alleen om te laten zien dat ik het ook zo bedoel als ik zeg dat ik de mensen hier in Nederland niet alleen wil verstaan, maar ook begrijpen. Nee, ik zou het vooral willen doen omdat Nederlands deel van mijn leven is geworden. Alsof ik dat ooit gedacht had. Maar zoals u zult horen, en ongetwijfeld ook weet, is mijn connectie met Zwitserland en de mensen die daar leven en wonen nog steeds sterk. En ik stel het ook heel erg op prijs dat zoveel hier naartoe zijn gekomen. Daarom zal ik mijn oratie in het Engels houden. It took me quite a while to now giving my inaugural lecture. To make the step working in another country, away from home, was in the end more difficult than I thought. I'd already had once before the opportunity to train how it would be during our stay in Melbourne, Australia, but making this step not just temporarily is different. It is an experience to get settled in a new environment. But of course you may think that there is hardly any difference between Switzerland and the Netherlands. Both are small countries, both are sharing quite some common expertise and knowledge, and also interest. Both have similar things that are important to people. But there is a difference. In the meantime, I've learned a lot. I've learned how to thoroughly discuss things. I learned that Limburg is well a province of the Netherlands, but that it's not Holland, even though they share some common interests. 5 years ago, I didn't know the difference. Now I do know. I also learned that if you get an invitation at 8 p.m., you're expected to be fed. And I learned that yes doesn't always mean yes, and maybe means no, but also that even a clear no always gives a chance for a second, always gives an option for a second chance. I've also learned about important differences in the healthcare system of the two countries, having basically no specialists in private practice, a much stronger influence of healthcare insurers, a different financial system with DRGs and now DOTs. Also in outpatient care in the Netherlands required a different setup of an approach to care. Comparing the systems and learning from it provides interesting insights in healthcare that we can use actually also to deliver care to our patients. But most importantly, I met many very friendly, helpful and enthusiastic people. I came along at a relatively young university, something I didn't know from the past, as both university, where I was working in Switzerland, have been established for hundreds of years. There are some things specific to a new university, I think. There is the problem of being questioned, of being forced to prove the importance of their own existence. This might be seen as a drawback, but to me, I think this is an interesting challenge. A new university also means having a spirit of enthusiasm, achieving something new, reaching out for success. The same reasons were my main drivers actually to do the step of going abroad. These attributes are crucial to tackle the challenges, I think, that are present for ongoing changes in healthcare, but also in education, and importantly also in research. Collaboration in this is very important, something that took some effort for me to be achieved, but I think we're really making progress within our heart failure cluster, within cardiology, but also with other departments and also across schools. An aspect of my work that I think is really, or I find really enjoyable. It's an honor to be part of a department where big discoveries in cardiology have been made. But this is obviously also asking for commitment. To a significant extent, this is visible. And I'm impressed about the expertise and knowledge that is available here in Maastricht. This is another important motivation for me to work here. Still, we must keep living up to this commitment and our expectations. The controversy between being questioned and wanting to perform and to achieve more shouldn't result to try to imitate what others are doing. In some ways, there are tendencies in this direction, I think, with, for instance, too narrow foci on very specific topics. Instead, we should ask ourselves, what are we really good in? And what are we wanting to achieve in the future? Obviously, it is not my task to do this in broader term, but for cardiology, I may dare to say that our strengths are not limited to one specific topic, but more the impressive variety of expertise that is present from bench to bedside. This became also obvious during, I think, the external review of CARIM that taken place this month. Even more importantly, the different groups are exchanging ideas and are collaborating. There are certainly fields where we could, no must, further improve. We also must be more visible in this from the outside. But we have good basis for to be very successful in this regard. In many ways, this is the topic of my speech today. The topic is, as you know, towards personalized medicine, and to me, this obviously means in heart failure. But how can I say that we should not focusing on one specific topic if I'm doing the same? So I think this is part of the challenge, being broadly focused. The contradictio in adjecto, the contradiction in terms, I don't think so. To me, personalized medicine is asking for more than what we have been doing in cardiology so far. And heart failure is a perfect playground for this, being complex end result of almost all cardiac diseases, dealing with patients that usually don't just have heart failure, but many other diseases, numerous adaptive mechanisms being important. Despite advances in recent decades, still much to be gained, both with respect to outcome and quality of life of the patients, and particularly a one-fits-all approach with very little attempts to go in a different direction. Heart failure is mainly, but not exclusively, a disease of the elderly. The prevalence increases with age, being far below 1% at the age of 50 and below, and increasing to 10% or more in patients aged 75 or more. Thus, at least every 10th person at this age group actually has heart failure. It is estimated that approximately 15 million patients suffer from heart failure in Europe, and that there is more than 1 million new cases each year worldwide. Heart failure is the most common reason for hospitalization at patients aged more than 65. And as a consequence, it's a very costly disease, accounting for approximately 2% of the total healthcare budget in developed countries. Usually, heart failure is a progressive disease. There are some exceptions, such as patients with myocarditis or result of exposure to toxic substances such as alcohol or chemotherapy. In the majority, however, patients don't completely recover from it. After initial presentation with symptoms such as shortness of breath, the patients usually can be stabilized with current treatment. Still, after a period of little symptom, which may vary significantly from months to decades, cardiac function progressively deteriorates with episodes of hospital admission. Function of the patients also gradually deteriorate until the terminal stage, finally leading to death. Some patients may also die suddenly from fatal arrhythmias at early stages. And obviously, treatment of heart failure is to prevent both as far as possible. And we have been quite successful in this during the last 25 years. In the late 80s, more than half of the patients actually died with advanced heart failure within one single year, undoubtedly one of the most deadly diseases then. Fortunately, different types of medication and also devices such as defibrillators and biventricular pacemakers have dramatically improved outcome in heart failure patients. Based on the large studies that have been investigated these therapies, one would expect a yearly mortality of 10% or even less. However, in clinical reality, figures are less optimistic than this. In our own hospital, approximately 10% of the patients that are admitted with the diagnosis of heart failure actually die during the hospital stay, and approximately 13% are readmitted to hospital within 1 month. These data have been collected in an international collaboration with 44 institutions in 8 different countries called Global Comparators. This collaboration is to improve in-hospital care by comparing data and also exchanging information about care. The big need of such initiatives is highlighted by these figures, and by the way, these figures are exactly or more or less the same also in other hospitals. So it's not an exception what I'm showing here. Also, during post-discharge care, there is still much to be won. As shown with these results from the Times-CHF study, which included a heart failure population with an age of 75, as we usually see also in clinical practice, you can see that 1 year mortality was still 20%, and within 4 years, half of the patients died. The question obviously arises, why are these figures much worse than what we might expect from the large clinical trials? There are several answers to this, but frankly, much is unknown about it. What certainly plays a role is the presence of multiple other diseases in the majority of the patients, so-called comorbidities. As recently described in the US patients hospitalized with heart failure, hospitalization primarily due to heart failure tend to decrease, whereas hospitalizations that are also accompanied with other diseases dramatically increases. For instance, or the most dramatic increase can be seen with renal failure being 10% in 2001 and increasing to 40% in 2009, or mental illness increasing from 25% to 38%. Other diseases increased less dramatically, but these figures really illustrate the complexity that is increasing in patients with heart failure. In such patients with these comorbidities, in-hospital mortality is more than twice the mortality of patients that have heart failure only. Another important reason is that in overall term that the adherence to the current recommendations by physicians could be better. In a survey, cardiologists, internists and geriatricians were asked about the way how they are treating patients with heart failure. Among other reasons for not giving beta blockers, an important cornerstone of heart failure therapy, were asked. Many reasons were given, but most of them are no contraindications for the treatment of these patients. For instance, COPD was given as an answer, also by cardiologists in 60% of the patient, or 60% of those interviewed, and 70% of the geriatricians and the internists. And this is actually not a contraindication. Various studies have shown that these patients equally profit. The only real contraindication is this. And taking this together, there is recently in the US a calculation being done theoretically what the impact actually could be on this. And what they calculated is that approximately 68,000 lives could be saved in the US each year if the treatment of heart failure was following guidelines in all patients that are eligible to that. Why aren't we doing any better than this? The complexity of treating patients with heart failure is certainly a key issue. Many caregivers, as well the patients, are involved in the treatment of heart failure. This not only includes cardiologists and general practitioners, but depending on the individual needs, also other specialists, heart failure nurses, pharmacologists, dietists, physiotherapists, and many others. Many questions in this complex network are not yet addressed. For instance, what is best coordination of care, the interaction between caregivers? What should be the communication and the documentation? What's the adequate approach, particularly to multiple chronic diseases? Because some of the guidelines are also contradictory if they are applied in the same patients. Benchmarking is not really clear. We have a lot to be done to improve efficacy and also reducing cost. We should integrate care also in these processes and also looking at the more globalized approach. And obviously, this is a list that is far from being complete, but in addition and most importantly, little is known about the importance of each of these hurdles. So what we are doing, or one initiative in this regard, is the Interact in Heart Failure study, which tries to answer many of these questions by investigating how the care process in heart failure is organized to define important bottlenecks. In this study, we are using a patient-centered, mixed method research approach. Thus, we have interviewed 33 patients from our outpatient clinic to determine how care was carried out in each patient. Aspects of this include the diagnostic steps being made, the therapy given, caregivers involved, hurdles the patients actually experience when they are receiving care. In addition, their cardiologists, their GPs, heart failure nurses were also interviewed, and presently we are actually interviewing patients that are coming from primary care, not being seen in secondary care or in our hospital. Moreover, the approach is being applied to 2 other regions outside the Netherlands, in Germany and Belgium, to actually see differences between different healthcare systems. The data are being verified by collecting data about the care process of another 150 randomly selected heart failure patients from patient records in each of the regions. And the experience we actually made so far and what we heard from the patients already resulted in some consequences. So it actually helped to better define the collaboration with the GPs in the region. The 1,5 Lijnzorg project focuses in heart failure on best treatment of the whole care process, particularly also long-term treatment to implement best practice in the region. Obviously, the main aim is also to define this more broadly and independently of the healthcare system to develop integrated care programs. An important basis for this will be the integration with ICT-supported care. There is considerable experience with ICT-supported care in Maastricht, and we are further developing and improving telemedicine in collaboration with an industrial partner. The aim is not only to provide easier access to care and improvement in aspects mentioned above, but to also substitute care to some extent, resulting in reduction in cost and still improving in care at the same time. Obviously, the ICT basis will additionally be used to implement the results from the other initiatives and will also be a basis for implementation for basic research programs or results from these programs we had in CARIM. Guidelines give recommendations regarding all patients with heart failure. However, these recommendations are evidence-based only in those below 75 years of age and with reduced left ventricular ejection fraction. In those with normal left ventricular ejection fraction, so-called heart failure with preserved ejection fraction or HFpEF, no treatment is known to improve outcome. Only a limited amount of trials have been performed so far, of which all failed to show significant benefits. One important reason for this failure is the fact that HFpEF is, in our opinion, not one uniform disease with uniform pathophysiology. Therefore, we suggest a completely different approach to HFpEF by establishing a new outpatient clinic for these patients with an important focus on extensive diagnostics. This will help to much better address the underlying problems in these individual patients, which then can be targeted with specific therapies. We are establishing an electronic database and a biobank in these patients to further develop treatment algorithms for best practice in these patients. A very strong translational part is playing an important role in this, as the cohort will provide sample for basic research questions, will help to define new questions that can be addressed in basic research, and will give the opportunity of bringing findings from basic research to these patients, which are in urgent need for a better therapy. Apart from this, the question arises to what extent personalized medicine is already implemented in the management of heart failure. The answer is to a very limited extent. Obviously, we are treating patients based on symptoms, and we are also treating underlying disease. We are treating complications of heart failure, and we are adjusting medication based on tolerability. But we would like to tailor therapy much more targeted to individual needs. This is to a large extent still fiction. Markers of prognosis might be helpful in this, but in clinical reality, this is presently limited to the indication for cardiac transplantation only. Some studies have been used biomarkers, particularly anti-proBNP, to better guide therapy in heart failure patients. Among those times CHF, in which I was substantially involved, is still the largest one worldwide. These studies suggested that BNP may be used, or anti-proBNP, to optimize therapy, but it's obviously a very non-specific approach. Other biomarkers and maybe also genetic profiles are not yet studied to guide therapy. Therefore, we are still using a quite standard drug and device regimen for the treatment of our patients, which actually is based on the guidelines, which I think is good, but is quite unselectively given to treat our patients with heart failure. There are obviously shortcomings to this. So I think it's very likely that premises are not the same for all the patients, and the effect of the treatment neither. As a consequence, the chance of a beneficial effect of a particular treatment is not really predictable, and many patients are treated that don't really profit from what we are giving. And the question is also whether there are better options than giving everything to everybody, and the answer probably is yes, but we haven't studied it so far. As suggested by studies such as Time-CHF, biomarkers might play an important role in this regard. Biomarkers are markers of biological processes. Broadly speaking, this may also include measures such as heart rate or blood pressure, but usually the term biomarker refers to markers that we actually can measure in the circulating blood, such as BNP. There are currently many initiatives on biomarkers not just in heart failure, using hundreds or even thousands of biomarkers. Given the complexity and the lack of understanding, however, of many details, I'm convinced that these initiatives are likely to fail, at least in the short and midterm. Therefore, we are using a different approach. In Time-CHF, we measured 20 additional biomarkers at all visits when patients were seen during the study. Currently, we are investigating how the interaction between these biomarkers and the medication during the time course of the study actually predicts the probability that the patients are doing fine. In collaboration with the Department of Knowledge Engineering of Maastricht University and an industrial partner, we are looking for individual markers that predict the effects of distinct classes of drug on patient outcome. The figure in the middle actually depicts an example showing a better response to high doses of beta blockers if the biomarker is low, but to low doses of beta blockers if the biomarker is high. This would be a completely new concept in the treatment of heart failure that could result in a paradigm shift. If this new concept can be confirmed, it would allow targeting specific therapy in individual patients. The results of Time-CHF are currently being tested in 4 other international cohorts of heart failure patients, including more than 5,000 patients. Both clinical data and blood samples to measure biomarkers are provided from these groups to us that we can further work out this concept. Initial results, as this one shown here, are very promising. After validation of these results, prospective studies obviously are needed and will be conducted. We are expecting to have the validation completed early next year. This would be a truly step towards personalized medicine for treating heart failure patients beyond current practice. Based on individual patterns of clinical findings and biomarkers, optimal therapy may be defined with high doses of drugs only where needed, but low doses or even omitting some drugs where required. This will result in least side effects, best outcome, and being most cost effective. In a later step, obviously, we are also looking at genetic information. In order to fully cover the picture we are dealing with, considering comorbidities is additionally needed. It is known that each comorbidity actually increases or impact outcome in a negative way. Thus, the risk of more than one additional disease is additive, resulting in a huge increase in risk to die in such patients as compared to those only having heart failure. In addition to the increased risk, making optimal medical therapy becomes close to impossible, as all these diseases require different treatment. Investigating heart failure in isolation, therefore, results in a major shortcoming for clinical practice. We are therefore investigating the interaction between heart failure and other diseases. One prominent example of this is the investigation of cognitive impairment in heart failure. Together with 3 other centers in the Netherlands, we are conducting comprehensive testing, including imaging using MRI of heart, brain, and cerebral vessels, cognitive assessment, as well as biomarkers. Thus, the interaction between heart, brain, and the blood flow to the brain is investigated in 3 populations, and that is heart failure, carotid stenosis, and patients with vascular cognitive impairment. Using such an integrative approach is also applied to other comorbidities, such as renal failure or COPD, particularly where needed most, which is obviously in patients with HFpEF. Finally, it is all about patients. We tend to forget that patients may have other priorities than we think they have. Asking them about their preferences and their quality of life is therefore crucial. We did so, and what we found was rather surprising. Thus, 3/4 of the patients wouldn't have been willing to give one single day of their remaining lifespan for a better quality of life, despite being elderly and despite having significant symptoms related to heart failure. This finding was completely unexpected to us, and it was not possible to predict the preference of individual patients. So this goes along very nicely with the investigation of the care processes. Asking what it is all about is crucial. Knowing is everything, guessing is nothing. Unfortunately, guessing is what we are often doing in care, not just of heart failure, but in general, but also to some extent in research. Our projects can be seen as a serious try to overcome this shortcoming. So the overall aim of the clinical heart failure group is therefore working towards personalized medicine in heart failure using a holistic approach. This doesn't only include heart failure itself, but as mentioned also comorbidities and patients' preferences. It aims to setting up personalized therapy applied to individual needs of heart failure patients, covering the full picture. Moreover, it aims to much better facilitate heart failure care by knowing the important processes, identifying and targeting bottlenecks, and creating a basis that is widely applicable. ICT-supported care will play an important role in this. Further development in collaboration with other academic industrial partners is key and will also include, obviously, applications to large grants. I'm convinced that this broad approach to clinical heart failure care, as well as research and also including research from bench to bedside, will help to overcome the obstacles. Very important in this is close collaboration with basic research, particularly because both sides are limited if there is no exchange. At first sight, and at addressed here, there is much to be done to even implement current knowledge in clinical practice. Only focuses on this would, however, mean stagnation, not only on longer term. Basic research is dependent on knowing the clinical important questions and needs a partner to bring their findings to patients, whereas clinical research is dependent on innovation and understanding of mechanism, just to name a few important aspects of such an interaction. There is, however, still a gap between the understanding of these mechanisms and clinical practice. This gap is significantly hindering progress. While within the heart failure cluster, I think we are moving ahead to narrow this gap. Still, there are also threats. Given the constraints to reduce cost in healthcare, the mistake is often being made to prioritize research and education much lower than clinical care, as clinical research can somewhat more easily be integrated in the clinical process or in the clinical care, and industry money is more easily available for clinical research. It is mainly basic research that is suffering from this. On short term, this saves money. On the longer term, this questions the justification of existence of a university. There are other ways to reduce cost and to be more efficient. Thus, effort should be placed on optimizing workflows, for instance. This has recently been started in our institution, and I think that's very good, but more needs to be done. Another example of this is the fact that the hospital and the university are still two different legal bodies, something I personally don't understand, and I also haven't heard any reasons for this that were really convincing to me. Maastricht, the university, with all the schools, and the hospital is aiming high, but has to be aware what the consequences are to live up with this. The new developing cardiovascular center, with the very ambitious aims, fits excellently in this. To be part of these new developments is very exciting and an important reason for me to work here. Thoroughly believing in it by all involved and putting the ambitions into practice even more than presently being done are crucial to reach these aims. I'm proud to be part of it and to be able to contribute to the success of it. At the end of my speech, I would like to express some words of thanks. All what I did and what I have achieved would have been impossible without the support of so many. A lot of them are sitting here in the audience. I would like to thank you all for being here. I would like to express my deepest gratefulness for all the support. At a moment like this one thinks back to all what happened and to all the people that played a role in this. I ended up with an unbelievably long list of people. It's obviously impossible to name all, and that does in no way means that I'm not grateful to them. Still, I would like to express special thanks to some, but please forgive me if I forget somebody or don't mention somebody personally. First of all, I would like to thank and remember my parents for all what they made possible for me. Unfortunately, they passed away years ago and can no longer be here. Still, I'm convinced that they would have been supported me in my decision to come here to Maastricht. Obviously, I'm celebrating a professional achievement. Still, without my friends, past and present, I would not be here. I really want to tell you all how important you are to me. I thank you all for what you have been doing, for what you have done and also been doing presently for me. And I would like to especially thank Mark Benny Bernheim, particularly for being my best friend for already more than 35 years. We have countless memories, but I don't want to go into details. I think it's better. Many colleagues from Switzerland, but also from other countries, have significantly contributed to my development and achievement. It's not possible to be successful without a mentor. Wolfgang Kiowski was my mentor, whom I owe much. Unfortunately, he passed away much too early, and I'm missing his advice. Many colleagues went along with me during my career. When I was a young assistant in training, Dani Schlossberg, but also later as staff. All those who did research with me were obviously particularly important. When I started with clinical research in Zurich, with special thanks to Dani Weilenmann, later in Australia and then back in Zurich, Christine Attenhofer, Hans Rickli, Erwin Oechslin, Christoph Scharf. Later, during my work as cardiologist in Basel, I had, among other, also the opportunity to participate in high-altitude research, which was just a little bit more than pure research. Alain Bernheim, Beat Kaufmann, Marco Macchiarini, and Susi Kriemler played important roles in this. A very special thank goes to all the Times CHF investigators and co-investigators. More than 100 people contributed to the success of the study, and also the patients, obviously. And it would have been impossible to do that without all of them. Of course, it's not possible to name all, but I'd like to mention particularly the assistants that were working in Basel. They really played an important role. And I'd like to thank especially Micha Mäder for his contribution. And the study wouldn't have been possible without Ruth Schindler. She was basically the heart of Times CHF, but contributed also to many other things. Here in Maastricht, I met many nice and interesting people, which makes it enjoyable, mostly, to work and live here. I would like to express my thanks to those who made it possible for me to come here, Matt Dahmen, Guy Peters, Michael Jacobs, and particularly Harry Kreins, Harry, who is giving me a lot of opportunities. I thank the executive boards of Karim and of the hospital and the dean of the faculty for the trust in me. Particular thanks also goes to the heart failure team of our department. Without them, it would be impossible to achieve anything. Christian, Vanessa, Nicole, and Simon. I would also like to thank Stefan Heymans for the collaboration, not just locally, but also in international studies, and the link between basic and clinical research. Leon de Wind and all the colleagues at Karim who are collaborating with me. My PhD students who are doing an excellent job with their thesis, but who also helped me a lot in many other ways, particularly Sema and Desiree. The same is also true for Mireille and Danielle. Very special thanks go to Sanders van Wijk, who really helped me a lot with so many things. Thanks to the heart failure nurses, particularly to Josiane Boy, for being a supportive sparring partner. Many thanks to all colleagues of the Department of Cardiology for a very pleasant collaboration and support, but also to all the residents and assistants in our department with whom I really like to work. Many thanks to the nurses, technicians and the whole staff of cardiology. And special thanks to our office, particularly Jan Bram, who is giving me enormous support. I would also like to thank the colleagues from other departments, particularly cardiothoracic surgery, and the colleagues from other schools with whom we are doing research, including Capri, with collaboration really starts picking up, and I think that's nice. Special thanks to Jan Hamers and Jos Kohls. And I would also like to thank the colleagues from the Department of Knowledge Engineering, particularly Ralph Peters, and the PhD student we are sharing, Nasser, for doing all the calculations I'm dependent on. And finally, I would like to thank many people from the industry who supported our research in all these years. In this regard, I would like particularly thank Christian Zaug. And I would like to thank one person very explicitly, my lovely wife, Gabriela. I'm most grateful to you for all what you have been doing for me and still doing for so many years and what you mean to me. I know that I'm asking a lot with respect to our current situation of living in two different countries, but also for sharing my sometimes strange ideas and believing in me even in severe weather conditions. The latter being meant not just literally. Ik heb gezegd.
Thank you very much, Professor Brunner La Rocca. I mean, as many of you know, I'm not a clinical expert, I'm not even a medical expert, so I was particularly triggered by your fascinating discussion on personalized medicine, and particularly the links you made starting with Switzerland, Netherlands, and then the issue, of course, between interaction between heart failure and other behavioral, I wouldn't say clinical diseases or other behavioral features. And I was wondering if things go well for Switzerland, we might meet each other. Well, there's still a couple of bottlenecks, Argentina. We might meet in a further weeks, etc. And I was wondering from that perspective whether your cluster, your heart failure cluster, also does research on the link between heart failure and watching football. As I noticed, not yet, you noticed the German study on this link between watching football and heart failure. So I'm delighted that we had this afternoon here several inaugural lectures in the middle, and that people were not watching football while they're being with us here. At least this was a very good timing from that perspective. Professor Brunner La Rocca, let me congratulate you on behalf of the university for being here with us and being part of this academic team here in Maastricht, this international team. Let me also congratulate, of course, the Faculty of Health, Medicine and Life Science, and particularly Nanne de Vries. And let me also congratulate Professor Van Dien Visser from the Raad van Bestuur van het MUMC+. I think whether we are not yet a legal entity doesn't matter, but we are still partners in academic research. You are all invited on behalf of Professor Brunner La Rocca for a reception, which, with the weather allowing, will be outside in the Refter. I close this session. Thank you.